Hey guys, it's Nessa. So we're going to be doing a video on chapter 55. We are going to start with gastritis. This chapter has a lot of overlap. So if you know one of them, you're going to know all of them. All right. Gastritis is inflammation of the gastric mucosa, which is the stomach lining, and it's actually classified by cause, cellular changes, and distribution of lesions. I totally meant to put this on private for my nursing class, so you guys are going to get a lesson in stomach disorders. Yep. Okay. All right. We have the acute and chronic kind. The acute is going to be more, the regeneration is going to happen within a few days. So, yes, thank you, Tiara. Oh boy. I totally did not mean to put this on Facebook land. Okay. Hi, guys. The the acute gastritis is you're gonna have a thickened red mucosa with a prominent rugae, and then the chronic. I'm just gonna keep going because trying to set it up again is just gonna be a little crazy. I love you guys. Thank you, Tiara. So my date is with you guys tonight. Yeah. Chronic gastritis is going to be patchy, diffuse inflammation, and as it progresses, the lining of the stomach atrophies. So that's going to be more serious. We have concentrated parietal cell reduction or decrease. So the source of intrinsic factor is lost. So then patients can't absorb their B12. So that becomes a really, really big problem. Whitney, we are doing gastritis right now. So this was supposed to be, again, private for my nursing class, but I forgot to put it on private. So hi guys. Glad I put on makeup. Basically, if we have chronic gastritis, that's going to lead to pernicious anemia. So the concentration of acid in the stomach becomes decreased, and so you get a higher risk for gastric cancer, and that's a big problem. Chronic gastritis is actually classified into 3 different types. So we have type A, we have type B, and we have atrophic. So type A is going to be non-erosive, inflamed glands, mostly located in the fundus and the body of the stomach. The type B gastritis is going to be in the antrum or the entire stomach. And then the atrophic gastritis is going to be diffuse inflammation throughout the stomach. And then it's a bigger problem because then you have destruction of the deeper glands, and patients are at really high risk of gastric cancer when they have atrophic chronic gastritis. The way I remember the parts of the stomach is if you are looking at a stomach, I can't believe I didn't put this on private. So the fundus of the stomach is the upper portion of the stomach. Fundus begins with F, and so does the word first. So you're going to see the first part of the stomach being the fundus. And then atrophic gastritis, I remember that because atrophic sounds like catastrophic, and if you have atrophic gastritis, then it can lead to catastrophic issues with gastric cancer. With the etiology, we really want to test patients for H. pylori. They may also have staph, strep, or E. coli or salmonella, so that becomes a really big problem with chronic gastritis. We basically want to figure out the cause so that we can treat it and then get rid of it. We also want to make sure that we check with patients to see if they've had long-term use of NSAIDs, alcohol, coffee, caffeine, or corticosteroids. Also, if they've had radiation, they're going to be at higher risk for chronic gastritis. The other problem we can run into is if a patient decides to drink Drano or accidentally ingest some sort of corrosive substance, then they can end up with chronic gastritis as well. This is going to be something we're going to watch for in our patients who are possibly suicidal or patients who have Munchausen's by proxy, but I don't know that we would really see that often. Atrophic chronic gastritis, we're really going to look for that in older patients. And if they are also autoimmune, could be caused by that. And then also the most common reason is going to be H. pylori or Crohn's disease. So the preventative measures we want to teach our patients, basically it's going to be diet, exercise, stress management. They shouldn't drink alcohol or take NSAIDs. They should stop drinking coffee and smoking. There's a chart on page 1105, and that chart is, let's see here, 55-2, and it gives you the key features of acute gastritis versus chronic gastritis. So acute is going to be rapid onset, nausea, vomiting, gastric hemorrhaging, dyspepsia or anorexia. The chronic gastritis is going to be a vague epigastric pain, and you're also going to have anorexia, possibly nausea and vomiting, but they're going to have an intolerance to spicy foods and fatty foods. So our assessment, we want to look for abdominal tenderness and bloating, and we also want to look for hematoemesis, the bloody vomit, or melena, the dark sticky stool. So, and also dyspepsia or heartburn. Also, if they have food poisoning, that's going to be an abrupt onset. We want to look for severe nausea and vomiting. Gastric hemorrhaging, of course, is a life-threatening emergency. So with the chronic gastritis, a lot of times that is asymptomatic until they have ulceration. So that is going to involve nausea, vomiting, and upper abdominal discomfort. And also, they're mainly going to feel that after they eat. So the gold standard for diagnosing chronic gastritis is going to be an EGD with biopsy, mainly to look for H. pylori or some sort of infection. And then make sure to tell your patients before they have the EGD and the biopsy is that they need to stop antacids for an entire week, or that can skew the results of their biopsy. Let's see here. Also, with acute gastritis, if they have a lot of bleeding, then they may need a blood transfusion. So just something to educate patients on. Really, they need to follow the advice of the nutritionist or anything that we give them. So treatment is going to be fluid replacement. They could also have a partial gastrectomy, a pyloroplasty, or a vagotomy. So we want to eliminate the cause or the underlying cause of whatever is causing the chronic gastritis. And especially, or if they have a disease that causes it, like Crohn's disease, we want to manage that underlying disease. So that's how we're going to approach treating these patients. They can take the histamine receptor antagonists, famotidine or Pepcid, sucralfate, aluminum hydroxide, aluminum magnesium, or PPIs, so proton pump inhibitors. There is a yellow box in our book. It says to let the doctor know if nothing improves, because sometimes that just means that we need to switch a patient's medications. So something to keep an eye on. Also, we can treat them with B12 injections if they do have the pernicious anemia. And then remind them too that if they're taking a prescription PPI or histamine receptor antagonist, that they need to avoid over-the-counter ones because they're already taking a prescription for it. So it's really important that we do medication education for our patients. Also, they can try a bland diet, nothing spicy. They can do maybe the brat diet. So just see how they do with it. They should also keep a food journal, and then they can note different foods that make it worse. So that could be helpful for them. Also, if they have H. pylori or one of the other infections, we can treat them with antimicrobials, Biaxin, amoxicillin, or tetracycline. Of course, we're going to wait until their results come back from their biopsy. So that is it for gastritis. So I will be loading the other videos privately. Sorry, guys. Unless you want them public, I will keep doing them. But the next one is peptic ulcer disease, and then we have gastric cancer. So we'll talk about those in a little bit, and then let me know if anybody has any questions, and I will save this and upload it to my YouTube channel for my classmates. Thanks so much, guys. Happy quarantining.